We are live.
Good evening, everybody. A warm welcome to one and all for today's CME. The topic being ocular prosthesis, technology, and technique.
Dr. Priyangsha, hold on for the presidential address.
Okay.
Sure.
Hold on, I will give you the idea.
Good evening, all my honorable members on the program today. We feel delighted that this is the 35th edition of the Ophthalmological Residence Teaching Series, the series which has been inducted, initiated, and propagated, maintained over the years by Dr. BNR Subudhi, along with Dr. Sabyasachi Patnaik. My great regards to both of you, sir. And our mentor, Dr. Ajit Babu Majji, who has done immense support for our EIZOC academic programs. I do invite our speaker today, Mr. Raju Kumar, the consultant oculist at the Center for Sight, Hyderabad. I invite our moderator, Dr. Priyangsha Chatterjee, and our panelists, Dr. Ashwini Kumar, Dr. Surjasnath Roth, Dr. Nitin Dhera, Dr. Prasanajit Das, and Dr. Sharmitra Behra. I welcome the discussants who all are present in the meeting today. With this, may I hand over to my president as well as Dr. BNR Subudhi to proceed further. Over to you, sir, and my president, Dr. Borua. Dr. Subudhi, sir.
Now, Dr. Jayant Borwaji, President sir, Thoda sir, few lines.
Hello.
Please.
Yeah. Good evening, everybody. I welcome you all to this ORTS seminar. Today, I'd like to thank once again Dr. BNR Subudhi and Dr. Sabyasachi Patnaik for the effort they have given to make this program very live and has continued for such a long time, and I wish that they continue for a very, very long time. And I'll at the same time I like to thank Dr. Ajit Babu Majji for his support in running the academic programs of EIZOC. I welcome the speaker, Mr. Raju, Dr. Raju, and I welcome all the panelists, discussions, and everybody. And with this, I think we go ahead with the seminar. Thank you.
Thank you all. On behalf of EIZOC ORTS program, I welcome you all to this program of 35, series number 35. And today's speaker is none other than Mr. Raju Kumar. He will be speaking on topic ocular prosthesis technology and techniques. So when we started this program, when we started this program on oculoplasty, I never knew that there are so many topics are there. So Ajit Babu was telling me always, "Arey, ruko, they will continue so many topics and so many episodes." Really, I'm thankful to him because he brought so many episodes, which really very much interesting. Not only the posted students, to all of us. And I must thank our EIZOC team, president, secretary, and the CSC for continuing this program under the new banner of new office bearers of EIZOC. So I'm really grateful to them. And mentor, nothing more to say about him because, as I told you already, he's always young and dynamic. And he selects topics and selects speakers from therefrom we get these ideas. I don't know, but at the end we could know that it's a wonderful program we had. And of course, I get almost every episode. I get most support from my coordinator, Dr. Sabyasachi Patnaik, who was earlier CSC of EIZOC. And today's speaker is none other than Mr. Raju Kumar. He is a consultant oculist, Center for Sight, Hyderabad. And he will be introduced by our moderator, Dr. Priyansa, and she will continue the program once I leave. And today's moderator is Dr. Priyansa Chatterjee. She is the chairperson and consultant cataract and refractive service, Dvita Eye Care, Durgapur, Kolkata. And today's panelist already, as told by our secretary, EIZOC, Dr. Ashwini Kumar. I don't know how many people know him. And really, the one young and dynamic person, in spite of all his problems, he is always there in any conference, state or All India conference. He is a consultant ophthalmologist, Mahavin Athar, Patna, and Dr. Suresh Natrat, one of the dynamic oculoplasty surgeon of not only from Odisha but also of Indian repute. He is the present network director, operations in charge, LVP Bhubaneswar, and is ophthalmic plastic surgeon by training and head this service at LVP Muthu Tulsi Chair Chandra campus in Bhubaneswar. Dr. Nitin Dhira, today's panelist, is also our chairman scientific committee, the director Sarada Netralaya and maternity and senior consultant Jamshedpur Eye Hospital, and Dr. Prasanjit Das, is associate professor Silchar Medical College in Assam, and of course Dr. Sarmishta Behra, the professor Bimsar Burla. She is always with us, either a moderator or panelist in all our episodes. And today's discussants are Dr. Shraddha Sattapal, JPM Rotary, and Smita Manta, MKC MCH, Parampur, Dr. Shatrupa Das from RIO Kolkata, Dr. Lipika Mishra from SC Medical Cuttack, and Dr. Amit Kumar also from SC Medical Cuttack, Dr. Priya Tiwari, JLL Medical College, Bhagalpur, Dr. Kumar Ashish from JLL Medical College, Bhagalpur, Dr. Pragya Bharati Nanda from Bimsar Burla, and Dr. Akshay Kumar from AIMS Patna, and Dr. Utkarsh Agrawal from AIMS Bhubaneswar, and of course Dr. Ritupurna Sahu, Bimsar. So as I told you, all these postgraduate students, the resident, they have come forward to participate in this webinar. So I request them to be present throughout the webinar and answer the questions said by our moderator or the speaker. So now it's over to our moderator today, Dr. Priyansa. Please do continue, introduce the speaker, and we'll continue the program. It's over to you, Dr. Priyansa.
Thank you, sir. Thank you, everybody. I would just like to warmly welcome everybody for today's seminar, the topic being ocular prosthesis, technology and techniques. Our speaker is none other than Mr. Raju Kumar. He's a well-known figure in the world of ophthalmology in our country. And at present, he's working as the Chief Ocularist in Center for Sight Super Specialty Eye Hospital, Hyderabad. He has a vast body of experience in this field for more than 15 years. He has been trained in LV Prasad, Hyderabad, and he has taken a special interest in artificial eyes, maxillofacial prosthesis, management of anophthalmic sockets, and pediatric patients. So I would like to request Mr. Raju Kumar to let me know if we can start with the presentation.
Yes, ma'am. Good evening, everyone. Thank you for giving me this wonderful opportunity to present on this topic, oculistry. So oculistry basically is combination of art and science. So what we do actually, so we are making artificial eye. So these artificial eye are basically custom-made artificial eye. So in India, we have option of custom-made artificial eye as well as stock eye. So if we see the age group, we can have a patient from a pediatric group as well as adult patient. So in this two photographs, we have two different cases.
Your slides are not visible.
Sunil, Mr. Sunil, you have to share the slides.
Slides are not.
Would like to request all the attending PGs, if anybody has any questions, they can put it on the chat and I can put them to sir as and when an opportunity arises.
Okay, so in this photograph, we can see that there are two patients. One is the patient who have undergone enucleation post retinoblastoma.
You're not able to see it. Mr.
see
Raju Kumar ji, you are not able to see it. The
Okay.
slides.
Okay, 1 second. 1 second. One second.
It's coming. Yeah. Yeah, make it full screen. Yes, now it's come.
Okay. Now it's okay, sir?
Yes.
Yeah. Okay.
So sorry. So actually, I'm discussing about this photograph. Actually, so there is no age group for the patient who can suffer with this kind of trauma. So in the first photograph, we have a kid who have undergone enucleation due to retinoblastoma. Similarly, a gentleman who have undergone this thing enucleation due to choroidal melanoma. So after eye loss, what happens to a person? So what we have to do if we find out someone who have lost their eye either due to any kind of trauma or due to any kind of malignant situation. So the main thing is that we need to guide them to a particular specialist, information about the treatment and realistic expectation. And we need to encourage the people to lead a normal life. It's very important because for the person who is losing an eye, so we need to give them a proper guidance and counseling. So will fitted custom ocular process definitely can change someone's lives. So just like for him, is kind of trauma to having a choroidal melanoma. After that, at least we can't give them vision. We can do the cosmetic rehabilitation for so that he can live a happy life for rest of his life. So what is ocular prosthesis? So ocular prosthesis is kind of healing art. So what we do actually, so we have a vast variety of patients from malignant patients, whether the patient has lost their eye due to trauma. So there are different kinds of patient we have. So oculistry, what is basically oculistry? It's a combination of art and science, which deals with fabrication and fitting of custom artificial eye. So why I'm telling you again and again about a custom artificial eye? We have another option, something called as stock eye. I'm going to discuss about that in the next slides. So what is an ocular prosthesis? An ocular prosthesis is a craniofacial prosthesis which replaces the absent or natural eyeball following an enucleation, eversion, or orbital exentration. So the prosthesis which fits over the orbital implant under the eyelids. So this is the anatomy what we have. So this is the natural eye, and what we can see, this is the implant. Over this, the artificial eye sits. So this is the basic picture. So this is the basically porcelain implant, normal silicone implant. Over this, we can fit an artificial eye. So the history of using artificial eye is not new. So earlier, the people used to cover their eye with a cloth, or after World War II, basically we started doing the artificial eye. Before there is an empirical method by which we are just like doing a stock eye practice. So the history of artificial eye is around more than 300-year old. So this is a schematic diagram in which it is clearly mentioned that this is the diagram of natural eye. This is post-enucleation and this is post-fitting prosthesis. So post-enucleation, we are fitting an implant. So there are varieties of implant. So just like in India, we are basically using an implant made from either acrylic or either made from silicone. So actually, the main agenda of my topic is to make the people aware about what is the difference between a stock eye, means ready-made eye, or custom-made ocular prosthesis. What are the advantages of custom-made artificial eye over stock eye? Because because earlier we have only one option of stock eye. Nowadays in India, we have almost this kind of services available in almost all the cities. Earlier it was limited to metropolitan cities. Now oculists are available almost in tier 2 cities also. So referring the patient to a person who is doing a customized ocular process is a better idea. Why? Because a stock eye itself is banned in you can developed nations like US, UK, because there are lots of complications of using a stock eye. So what are the advantages we are getting of custom ocular processes over stock eye? So with the definitely with the custom ocular processes, we are getting a better fitting, better cosmosis. There will be less complication as compared to stock eye or ready-made eye, less discharge. In this kind of just like for with custom made ocular process, we can do a modification, and we are using a medical grade PMM. Similarly, for the stock eye, it's an empirical method, so we are not getting an adequate fitting. Patient satisfaction is not up to mark. They are more prone to getting infection, and patients are getting frequent discharge. Due to that, what is happening later on, maybe after 10 years or 15 years, the socket is getting contracted, and ultimately the process will start falling down. So, and one more thing, these processes are made from low grade plastic, and there are few evidence that due to using a stock eye for a prolonged period, a few patients developed just like a severe complication, just like socket contracture, and and maybe after 10-15 years they won't be able to use the artificial eye. So custom-made ocular prosthesis is a better option. So this is an example of a patient who, she's a young female, she's using an stock eye, and she had lost her lower fornices. So in this kind of situation, what we need to do, the patient again, she need to go reverse, means the patient need to go for fornice formation, suturing, surgery, and after that we can fit an custom made artificial eye. So ultimately, we are pushing, if we are giving a stock eye to the patient, we are pushing the patient again for a secondary surgery. So nowadays, custom-made ocular processes means we are ocularists, so we are available almost throughout the India. Just like earlier, just like few places like Hyderabad, Delhi, Mumbai, we have such kind of lab. But now we have labs throughout the India. Even we have labs in Patna, we have labs in Kolkata, we have labs in Bhubaneswar. So the facility is available now throughout the India. So this is the basic difference between a custom-made artificial eye and a stock eye. Stock eye and custom-made artificial eye mimic like same. It looks like same. The major difference is the price factor, because for the custom-made ocular prosthesis, as we are dedicated to this work, so and we have investment for the lab setup, and just like we have to run the store, so the charges of the custom ocular prosthesis will be slightly more as compared to stock eye. Stock eye is easily available. Anybody can fit in empirical method, but we are not getting that much detailing in case of stock eye. And considering the complication, the price of custom ocular prosthesis is much cheaper as compared to stock eye. So who need artificial eye? What are the indication of artificial eye? There are multiple situations where we need to guide the patient for artificial eye. Even in case of ophthalmos, so even the parents or the patient, they don't know that if in case of anti-staphylococcus, if they will undergo evisceration, they can get a good prosthesis. So the starts from first thing, it's congenital anophthalmos, microphthalmos. So in generally everybody is getting this kind of cases, microphthalmos and anophthalmos, and early intervention is very important in case of anophthalmos and microphthalmos. Thiatrical bulbi, atrophic bulbi, these are the one of the main indication post trauma or post just like any kind of surgical procedure. If you're getting any patient like this, thiatrical bulbi, atrophic bulbi, this kind of patient, even we can fit an artificial eye without doing evisceration. If there is no ciliary tenderness, if the patient is comfortable enough, we can give the artificial eye directly. Post enucleation, post evisceration. Post enucleation, basically in case of any kind of malignant cases, we can fit an artificial eye. Post evisceration, painful blind eye, contact is okay. These all are the examples or indication of custom-made ocular prosthesis. So types of custom ocular prosthesis, what is available right now in India. So we offer variety of custom-made ocular prosthesis, just like lightweight prosthesis means it's kind of hollow process, very lightweight process, just like self-lubricating prosthesis. If someone have lost lacrimal gland, so we can have a prosthesis with a self-lubrication also. Prosthesis crutch, crutch for the ptosis correction. If the patient have third nerve palsy, in that situation, we can have this kind of prosthesis. With the help of this process, we can open the lid. Silicone orbital prosthesis, scleral cell for patient who need artificial eye in case of thiacical bulbi. Custom conformer, iris pendant conformer, hydrogel circuit expansion for this thing, management of microphthalmos and anophthalmos, glue on, spectacle mounted excentric prosthesis and facial prosthesis. Post COVID, we have done lots of patient processes, particularly for the facial and exenteration processes. Earlier, I used to do around 3-4 cases in a year for the exenteration processes. Post COVID, I think post the second wave, I have done around 50 cases just for the exenteration processes. So this kind of things are very important. Particularly, we have more patients in a young age group who have suffered due to black fungus. Osseointegrated process is kind of implant retained orbital prosthesis. This is a simple example of microphthalmos. So this is a young kid, is around 9-month or 1-year kid. So this child has straightforward undergone enucleation surgery, and after that we have fitted a custom-made prosthesis. Right now, the age of this kid is around 12 years. So maybe he have undergone the surgery somewhere in 2013-14. So he's doing well in his life. So because we don't have any option, if we'll keep the eye like this, maybe that later on we have to do the surgery only, because there is no vision in his left eye. So this is a case of severe microphthalmos. So what is the management of microphthalmos? The management of microphthalmos is very simple. Even for the management of microphthalmos, we don't need oculist. We need to start with a simple procedure, something called as serial socket expansion with a normal regular conformer. So in this case, I kept changing the conformer every 6 weekly, and slowly, in the last photograph, there is something called as this thing, iris pendant conformer was fitted. After that, the patient has undergone one second. Give me 2 minutes. Give it. Yes, sir.
Please make it full screen.
Yeah, sir.
Thank you.
So in this slide, we have in the last picture that the child is using a iris pendant conformer. After that, the child has undergone enucleation surgery, and this is the post-operative 6 weeks, and finally we have fitted a custom-made artificial eye. So this is the timeline, just like from here to here. So we have achieved this result within a year. So why to start the management of microphthalmos or anophthalmos at a very early age? Because this is very important. Because if you delay the case, if there is a bony contracture, if you are doing the job in 1 year or 1.5 year time, for the same thing, maybe you have to wait for around 3 years or 4 years. So the management of microphthalmos is comparatively easier as compared to anophthalmos. Maybe for the management of anophthalmos, maybe it will take uh, uh, 2 years or 3 years for the complete expense. So this is example of a prosthesis post enucleation. This is the in the first photograph, the child has undergone enucleation due to retinoblastoma. In the second slide, the this lady has undergone enucleation due to choroidal melanoma. So this is a case of post-evisceration case. This is a case of anterior staphyloma. The patient has undergone this thing evisceration, and we have fitted a custom-made artificial eye. So what with the custom-made artificial eye, the what we are gaining, we are gaining the confidence back of the patient, because this is very important, particularly in case of children. So they don't know what is happening to them. Even they don't know what is artificial eye, and sometimes they keep asking the parents that when they will get back their eye. Even they don't know that whether their parents' eyes are like that, this only, or whether we all are using artificial eye. They are so innocent. They are thinking that we are also suffering with the same kind of problem. So for particularly for the young females or male, it is very important this cosmetic rehabilitation, because it changes their life, particularly those who are working, those who are working in any kind of service sector. So this in this slide, you can see that we can just like change the complete appearance of any patient. This is a case of failed DFG. Sometimes we are doing multiple surgery, so we are ending with this kind of result. All the cases we are not getting a good results. Sometimes if the patient has if the patient is having a history of EBRT, in that situation also we have to struggle a lot, because either this kind of process patient either we can fit a glue-on prosthesis, or we have very limited choice. But with the grace or with the help of great surgeons, we can fit an artificial eye in this kind of situation also. So the next slide, this is something called as orbital prosthesis. So this kind of prosthesis is comparatively new in India. So we are practicing this kind of prosthesis almost 20 years plus in India. So nowadays we are just like procuring the material in India, but earlier we used to import the material from USA. So exentation is a surgical procedure involve removal of all soft content of the orbit. So entire thing has removed. So facial prosthesis made from silicone, just like that ocular prosthesis made from acrylic, but facial process made from silicone, or we can make this thing facial process with the help of acrylic also. So what we do, we design the this thing complete facial processes, and with the help of this thing silicone glue, we stick the processes over the skin. If skin is missing, then we can do just something called as a spectacle mounted orbital prosthesis. So nowadays we have just like advanced technology in which we can scan the picture, and nowadays, particularly in UK, in King's College of London, they have started printing the entire orbital process with the help of 3D printer. Still, it is in research phase, but maybe later or sooner, this kind of facility will be available in India also. So this is an example of a patient who have undergone exenteration. So the exenteration processing was fitted in both cases. So in this picture, even if you can see that the first picture, that ladies have undergone the exenteration. After that complete healing, we have fitted the this thing silicone prosthesis in this picture, if you can see, this is something called osseointegrated implants. So with basically dental people and implantologists, those are dental implantologists, they are doing this kind of surgery. We have also done one case long back with Dr. Santosh and Dr. Neeraj Chandrakar from Raipur. So one case we have done in Center for Site Hyderabad, but majority of the cases is done by this thing dental people only. This kind of osseointegrated implants. So this is my presentation about the ocular prosthesis and orbital prosthesis. So if anybody having any query or question, they can ask me.
Thank you, sir, for your presentation. Um, does anybody have any discussing points or questions?
Priyansha, let me start. Okay,
Yes, sir.
Raju, this was a very good, excellent results. And having seen prosthesis and rehabilitating patients for quite some time, very, very fascinating to see the results and very difficult ones, some of them. The first question I have is you did mention the difference. And I think one of the major objectives of the presentation, like you mentioned, was to differentiate the stock eye from a custom ocular prosthesis. And you mentioned one of the things is, of course, the kind of detail with a picture. The kind of detail that goes into a custom ocular prosthesis is far more and can almost kind of be very, very similar to the existing eye. But do you want to also probably, highlight to the overall listeners about what are the other things which make a custom ocular prosthesis also unique in the rehabilitation? Because the way it sits on the eye, the way it conforms to the shape is also something which, for which the rehabilitation, that means once you fit a stock eye versus a COP, how the socket undergoes long-term changes is also very different.
Yes, sir, definitely. Because the main problem, what you are saying, sir, fitting. So in case of a stock eye, we have empirical method. So that the backside of the stock eye will be just like similar in all the stock eye. But suppose in case of custom-made ocular prosthesis, suppose the patient is having implant migration, cellophonicis, or if the implant is missing. So when even in this slide, if you'll see the picture, so what do? We take the measurement with the help of calcium alginate. So we are getting the exact volume. The concept of custom made ocular prosthesis is to just like virtually we don't want any hollow space between implant and the prosthesis, because if there is any space between the implant and the prosthesis, tears will get keep accumulating there, and the patient will keep getting discharge problem. So this is the main valid point. In case of custom ocular prosthesis, virtually there will be no space between the implant or between the eye and the prosthesis. But in case of stock eye, there will be a gap between, there will hollow space between the implant and the prosthesis. First thing. Second thing, the material what is used in case of stock eye is a simple polythene, simple plastic. What we are using is a PMMA. It's a medical grade material. And if just like with the reference of my dentist colleagues, so that chemical content in custom made ocular prosthesis PMMA, what the PMMA we are using is kind of heat cure PMMA. Means there will be very minimal chemical content. Maybe there will be around 3 to 5% chemical content, monomer content in the custom made ocular prosthesis. Similarly, in case of a stock eye, there will be around 20 to 25% chemical content, means monomer. And stock eye is made from a cold cure technique, means they are not doing a heat cure, means we are boiling our processes at 120 degrees Celsius. Those processes are simply just like frozen. So they are using a different kind of material. They are using as just like seat technology. So the main problem arises there only. So that in case of stock eye keep irritating the socket, and there will be reaction between the prosthesis and the socket. So the first and most important thing is in case of fitting, in case of material, there are two major factors. The third thing comes with the this thing surface. Stock eye also looks very smooth. Later on, there will be a depositions. If there is any tear deposition, this thing due to some depositions, there will be a problem in blinking the eye. The patient won't be able to blink. So in that scenario, the patient will get more discharge. Custom-made ocular prosthesis, we are giving a glass finish. So in that situation, there if the patient is using regular lubrication or if the patient is hygienic, the chances of complication is very less. I'm not saying that we don't have any complications. Definitely, it depends upon the patient. Just like if the patient is not hygienic, if the patient not cleaning the processes on a monthly basis, if they're not taking care of the process, definitely in case of customized ocular process also there will complication. But if you're considering as compared to stock eye, if someone is using a stock eye after 10 years or 15 years, definitely the patient need to undergo FFS surgery or socket reconstruction. But in case of custom-made artificial eye, it's almost I'm doing this job since past 16 years, since 2008-9. So I have done more than 6,000 cases, or maybe I have seen more than 15,000 one-eye patients. So that complications in case of custom-made ocular prosthesis is very less as compared to stock eye.
Surya, you are muted.
Yeah, no, I think that was a very, very nicely listed differences, Raju, and thanks for that. Just wanted to just also add, because, large number of ophthalmologist friends here, that the kind of reaction you're talking about. So in the clinic, when you take a custom ocular prosthesis versus a stock eye, you can see how the socket is reacting. And even on a slit lamp, when you look at the socket, the one which has been constantly using a stock eye, you would see a significant degree of papillary reaction because of the friction that it causes on the entire surface. And it is not even touching the entire surface. It is probably touching on few areas of the surface. And because it is not conforming to the surface, that is it. Compared to that, when you look at a COP, the surface is exactly conforming to the surface. It has been made for the purpose, and that shows on the surface. So the surface looks much better. And we all know that for a socket reconstruction, the surface, the ocular surface is extremely important, not only for maintaining the prosthesis, but also to making sure that future rehabilitation continues to happen. Thanks, Raju.
I would like to ask a question to Dr. Surya.
Sure, ma'am. Please go ahead.
During the mucormycosis time, when we had to perform exenteration in certain cases, like in those cases, when should we really think of a prosthesis?
So, if you're specifically talking about the mucor sort of epidemic, actually, then the timing of thinking about an orbital prosthesis is probably going to be only after we are 100% confident that at least the infection thing has been sorted out, and that was taking quite a long time. That's the reason I'm saying that. So to differentiate two groups, I would say when we are doing an exenteration for, let's say, an adnexal malignancy like a squamous cell or sebaceous that has gone to the orbit, we would do an exenteration. And some of the pictures that Raju showed were actually a lid sparing. So we will do predominantly an eyelid sparing exenteration. And that in that kind of a scenario, we would probably be ready, I would say, think in probably 6 weeks to 8 weeks, the skin would have healed. And that's the advantage of eyelid sparing exenteration, because the traditional approach where the eyelids were also actually taken out, then the healing would have taken much longer. But if you're looking at a mucor, I think I would give it a little more time just to be sure that the infection issue has been taken care of as far as the fungal infection.
Thank you.
Any other questions from residents and others? I was waiting for some inputs from them or anybody else.
Raju, can you stop the sharing of the screen?
Okay, sir.
Hello, just one information I would like to have from Mr. Raju. He was talking about that the customized lab is there in places like Patna also. So can we have the address of this place? Because I mean, these cases we deal very less often, but it does come across. So what we do, the general ophthalmologist as such, we keep the stock eye prosthesis and then use it. But if it is available in a place like this, definitely
Actually,
one
sir,
can wait for a couple of till it is made and
Mr. Rajiv Prasad,
we can-
Mr. Rajiv Prasad from Patna, I think he used to do the processes in
oh,
Patna,
Mr.
sir.
Rajiv, oh, he used to work with me, but most of the time he's out of town. His
No,
job is
actually,
very-
he had someone from Delhi, sir. So he's taking care of, I think,
Okay.
Patna and Jamshedpur. So we have
Okay,
actually
right,
earlier patient from Bihar used to come to Hyderabad or Sankanetralaya. Now we have facility available in Patna also, sir. So Patna, even because
Okay, right.
I used to also train my fellows, so we have facilities available in Patna, Jamshedpur, Kolkata,
So
Bhubaneswar.
that means if I contact Mr. Rajiv,
Yes,
he'll be able to help sort
yeah,
it out.
definitely, sir.
Yeah,
Because
yeah. Okay.
even in Bhubaneswar,
Thank you,
everywhere,
sir.
sir, Vijayawada, Visakhapatnam. So nowadays we have more people available.
And normally, how many days you take for the customized?
Sir, yeah, for one patient, ideally, if we have one patient, 1 day is enough, sir. Okay, 1 day is enough to complete the entire job. Around 6 to 8 hours if you're doing one session, or 2 days in generally. Just like if I'm working in a hospital setup, 2 days, and if I'm doing just like on my setup, so 1 day is enough, sir. 6 to 8 hours.
I had one more question, Raju. And this was related to the motility. You know, that's a very common question that we face, let's say, from a patient, that if you were to do a prosthesis, then how good it is going to be as far as the motility of the eyes are concerned. Some people really ask this question because is it going to, number one, close just like my normal eye? And many others ask, do you think it's going to move side to side and up and down like my normal eye? I think that comment would really help people explain to their patients and also rehabilitate them. Raju, can you? Yeah.
Actually, sir, movement is one of the most important question. Just like they are not they are least concerned about the appearance and this thing cosmetic. So particularly those who are undergoing fresh enucleation, just like for the choroidal melanoma, or those are having just like senile. So they have this kind of prominent question. So for me, movement we are giving a range around 40 to 60%. This is not we are telling that maybe it will move in between 40 to 60%. Sometime I'm getting patient once in a year, maybe few patient we are getting, those patients who are getting around 80% movement also. Those are rare cases. But in generally, what I observe, we are getting around 40 to 60% on an average movement. And one more thing is that when the patient is asking about the movement, we have to tell them that our eyes are not moving in just like in a synchronized manner. It's moving in opposite direction to each other. So if someone is moving their his eye in the left side, so definitely he's not going to get the same identical movement in the his good eye. Sorry, as compared to good eye, he's not going to get the identical movement in the artificial eye. So we have to give them a range. And one more important thing, what I tell to my patient, suppose on the day when I fitted the prosthesis, maybe particularly on that day, patients are very much keen about the movement and everything. So what if the patient is getting around 40% movement or slightly lesser movement, I counsel them that initially, just like today I have fitted the prosthesis, now give some time, maybe that there will be just like better integration, or the process is going to just like sit properly on the implant, definitely your movement is going to improve. In generally, if the patient eyelids are okay, if there is no ptosis or if the sockets is just like less congested, definitely patients are getting movement on an average in between 40 to 60%. So we have to counsel the patient. Suppose on the specifically post-operative 6 weeks, we have treated the process. If the patient is not happy with the movement, we have to tell them, give some time, definitely you are going to get the movement. Movement are less in case of a pediatric patient. In as compared to adult patient, pediatric patients are getting less movement. I don't know what is the reason. Maybe their processes are slightly bigger. I used to fit slightly bigger process in case of pediatric patient, so that we don't need to change the process on frequent basis, because they are already facing a financial burden. Maybe due to slightly larger size of the processes, also we are getting less movement. So if the process is just like adequately fitted, or I can say if the process is slightly smaller as compared to the good eye, no, the patient will get a better mortality.
Movement has bearing on the underlying procedure also, no? Like
Yes, sir.
evisceration, the movement will be much better compared to enucleation and exenteration.
Actually, sir, if you ask me, frankly speaking, if in case of thicycle eye, we are getting better movement. The best movement we'll get in case of thicycle eyes. In case of evisceration or enucleation, if it is just like myconjunctival enucleation, or it depends upon the implant size also, sir. If you have a very small implant, just like 14 implant or 12 implant, we'll get less movement. If you have adequately 18 or 20 implant, if the socket is healthy, definitely we are going to get better movement. One more thing is the ptosis, because out of 10%, we are getting around 3% who have some kind of ptosis, particularly in case of anti-staphylomas or in case of trauma cases, we are getting ptosis. If the patient is having ptosis, definitely that movement will get compromised, because that eyelid is sitting on the prosthesis, because we, with the help of prosthesis only, we are lifting the lid. In that situation, definitely the movement will get compromised, sir.
Can you give me a fair idea about the cost of the, the different kind of prosthesis?
Actually, sir, sir, to be honest, we have basically two kinds of material. Okay, earlier we don't have Indian material. When I joined LVP in 2009, at that time we have only one choice of we used to import from Canada. Now we have two options. One option is made in India, purely made in India. One is we are importing from, there is a company called Factor 2 from USA. So, for example, if I'm telling about a simple thing, just like corneal button. So, if we are buying a corneal button, it costs us around 300 rupees. Similarly, if you're buying a corneal button, 3D corneal button from US, it costs us around 1500 to 1800 rupees. So, considering the cost factor, just like for any Indian, for the Indian material, we are charging anything in between 15 to 18,000 rupees. For the imported material, we are charging around anything in between 25 to 30,000 rupees. So in India, particularly, just like a majority of the hospitals, those who are doing the process on an active basis, so we have a price range of around 17,500 to 35,000. It depends upon that types of material what we are using. First thing. Second thing, there is something called as just like we are giving a free of cost replacement. If anything happens to the process within 3 years, we are giving free of cost replacement to them. So the cost wise, ideally, if you'll ask me, the ideal cost of the processes, it can be somewhere in between 10 to 15,000 is okay, sir.
Is it one-time investment, or you have to change again?
Actually, sir, there is no expiry date on artificial eye. Okay, so if suppose if we are fitting an artificial eye to a 20-year-old male, and if we want to continue the same artificial eye for next 10 years or 15 years, there is no issue at all. But what will happen maybe after 5 years or 7 years, due to change in the BMI, due to change in the just like if someone has gone enucleation, there definitely there will be fat atrophy. So due to the change in the fat, just like fat composition, and due to change in the implant position, definitely there will be some gap between the processes and the implant. So ideally, if you'll ask me, we need to change the artificial eye every 5 to 6 years, once in a 5 to 6 years, But if you'll ask my average, my patient in general, they uses just like for adult patient, minimum 7 to 9 years they can use easily. Even if the just like there is a lady Sanno Rani. She the first ocularist in entire Asia. She used to practice in Aligarh, Uttar Pradesh. So I have seen few patient the same processes. The patient used to use the same process for 20 years or 25 years. So there for the customized artificial eye, it depends on the patient financial status and their wish. Majority of the patient, they change the processes because initially we tell them that this process is going to last for 5 to 6 years. And one more plus point, sir. Suppose if the patient is using the artificial eye for 5 to 6 years, after that, if they are changing the artificial eye, they are getting an additional artificial eye. Suppose if I have a patient from Guwahati, Assam, if the patient is having two artificial eye, in that situation, patient don't need to come for the polishing again and again. They can send the one artificial eye through courier. I can polish it. I can send it back to them. So it is more productive. So majority of the patient from Western Uttar Pradesh, Bihar, Assam, or Kerala. So if they are coming to me, if they have two artificial eye, I encourage them. No need to come. We can polish the processes. The entire thing can be done in 300 rupees only. So keeping a spare process is a better idea, sir.
I may want to just add there that Raju, we also probably have to keep in mind. So let's say talk about the duration of how much the prosthesis. We need to understand that when you are actually using a prosthesis, essentially the most important thing is the implant that Raju talked about. Now you want an orbital implant which should give you a volume replacement of somewhere around 75 to 80%. That means if you're trying to put a small orbital implant, you are actually increasing the size of the prosthesis. And the larger the size of the prosthesis, the more problems you're likely to face. That's very, very important as a surgeon to understand. Number one. Number two, over a period of time, even if we try to do a 75 to 80% volume replacement by a reasonably sized orbital implant, the prosthesis is actually resting only on the lower eyelid. Whereas anatomically, the eye, or let's say the eyeball, is actually with the help of septa, is actually floating in fat. So it's a non-physiological situation. And when you have a non-physiological situation, obviously depends upon how the care of the prosthesis is done and things like that. But generally around 5 to 6 years, you start seeing changes in the socket also appearing. And the moment the socket changes appear, as surgeons, what happens with us is the moment we try to do a little bit of a touch up in the socket, the prosthesis unfortunately also has to be changed a bit. So I think that's the kind of thing that we have to keep in mind. But yes, absolutely, very well kept prosthesis. We ourselves have seen people using it well beyond 5, 7 years. And that's something which is possible only with custom ocular prosthesis.
In LVP Bhubaneswar, do we
I
have?
think no one else is asking questions. Only Surya and.
Yeah. In Bhubaneswar, it is available?
Yes, sir.
Yes,
LV Prasad.
LVP Bhubaneswar.
Surya?
Yes, absolutely. I mean, you see, if you are practicing ophthalmic plastics and you don't have a custom ocular prosthesis service, you are literally handicapped.
Handicapped,
You
yes,
know, because
definitely.
so much of the procedures, we
Can't
have to be hand in
imagine.
glove.
Can't imagine.
Yeah, otherwise, there is very little that you will be able to do. So we definitely do custom ocular prosthesis, and that's definitely a very, very critical arm. I just wanted one particular question again, Raju, is that one picture you showed towards the end, which was a failed DFG, very bad socket to deal with. And again, an excellent job of trying to even retain a prosthesis. But you have in these scenarios like we face too, you end up having a prosthesis where there is a significant lag of thalamus. So while a static look is good, but essentially with a blink, the eye is not able to close over the prosthesis, the eyelids, I mean. So what are the specific changes that you do in such a bad socket or a difficult socket to be able to use the prosthesis?
Sir, actually, if you'll ask me, there are around 20% patients who have a problem with this thing blinking. So this thing not blinking properly or inadequate blinking is the major problem. Those patients who are unable to blink, they are getting more discharge problem. Thus, there will be socket contracture. Later on, there will be entropion. So, if the patient is having history, particularly of using an stock eye, so they are getting this kind of problem. Fresh patient who are using customized prosthesis post surgery, rarely we find this kind of problem. Suppose if the main problem is the scarring. The main problem is the scarring because the patient is using the stock eye for prolonged period, so there will be a significant scarring, and just like microbilifron, there will be just like there is just like less elasticity in the particular in the upper lid. So if you have such kind of patient, so I what I used to do tell them to do the exercise, just like orbicular exercise is the most important thing for them. So with the help of exercise only, we can just like correct that thing. In few cases, I have tried a temporary sutures also, just like if someone is
Inferior quadrants.
yes, just like particularly in case of children, if they have blinking issue during summer vacations, I try. In case of even the for me the worst scenario is the EBRT. Post EBRT, just like the post choroidal, just like post enucleation. Again, if the patient is undergoing EBRT, that is the nightmare for me. That is the worst situation because even in case of children, even in case of adult patient, it's very difficult to manage, sir, because repeated 5-year view also is causing just like you can say erosion of the just like tissue. Just like recently we have one patient who have undergone EBRT and post EBRT. The patient have gone multiple times 5 injection. After that, the patient have gone FFS surgery, and finally that there is an implant extrusion. So it's a just like nightmare for the surgeon as well as for us also. And in generally, if the patient is unable to close the eyelid, what I suggest them to keep doing the exercise. And in case of pediatric patient, I used to convince her to do just like temporary tarsorrhaphy for 15 days, 20 days. Sometimes it works, sir. Sometimes it works, sometimes it don't work. It depends upon the scarring and the flexibility, sir.
Right. No, I absolutely understand this. Very difficult patient sometimes. There's one question in the chat box, and that's from Utkarsh Agarwal. I think we see him there, and that's about bio-integrated prosthesis is the question. Are these available? Or
Actually,
are they
sir, uh, what sir is asking in India, maybe I have we are not doing that kind of thing because that porcelain implant, I think sir is asking about porcelain implant. So particularly just like in LBP or in Dr. Sandoz, we don't do porcelain implants. So porcelain implant is a wonderful thing, but it's not good to comment on LVP that they are not doing. But in generally, we don't do porcelain implant. What is the drawback of doing porcelain implant? That there will be significant, there will be implant exposure, maybe 3 years, 5 years, 10 years. Definitely, there will be implant exposure. Though the implant exposures are very bad, because in case of porcelain implant exposure, once we are going to take out the implant, entire thing will come out with the implant, whatever the fat and everything. So in that kind of situation, if you're taking out the implant, if you're doing a DFG, it's very difficult. What sir is asking about this thing, just like uh, integrated process, implant integrated process, I think sir is asking. So implant integrated process is basically pegging, or you can say attaching the process with the implant. It's done basically in Northern America and UK. In India, till now, we are not doing that kind of integration because considering the patient hygiene, as India is just like tropical country, consider our temperature, consider patient hygiene, consider accessibility. So, in my knowledge, we are not doing that kind of processes. My one of colleague from Delhi, he have a patient somewhere from I think Iran or somewhere. So he have undergone a porcelain implant with pegging. So he have done one case in Delhi, but the surgery was not done in India. I have seen cases from Dubai. There they used to do this thing, also integrated. Sorry, not also integrated. This thing, foracetylene implant. Even in maybe somewhere, sir knows that about this. Maybe in 2003-4 in LVP also we have done this thing, foracetylene implant. But the majority of the cases there will be complications. In Mumbai also there are few surgeons who is doing this thing, porcelain implant. But in my knowledge, what I know, majority of them they don't prefer porcelain implant, because considering this thing. The only advantage with porcelain implant is that we are getting better movement. Or if you have any plan to do an integration, then porcelain implant is advisable. Considering the surgeon benefit and the patient benefit, our silicone implant or this acrylic implant is the best, because that the chances of complication is very less. Because if you are doing any kind of just like prosthetic implant, that this medical representative they used to counsel, even they used to keep coming and they used to convince us, particularly sir, that there will be no complication, less complications, this that. But particularly they are giving data from USA, not they are not giving the data from India. Because in India, that what I observed, that we are just like if the patient keep using this thing, steroid combination, just like moxi D or anything toba D, so repeated using of steroid for prolonged period, it also causes thinning, that there will be thinning on the just like implant surface. So even the main problem with porcelain implant is the implant exposure. So in generally India, majority of the oculoplastic surgeons they don't do this kind of surgery, sir.
So I think, Utkarsh, hope the question is answered. So essentially, the integrated form of implants. Raju mentioned about porous polyethylene, but you can also have absolutely something that is drawn from coral, like hydroxyapatite, far more expensive. The beauty of the thing is it will get integrated, but one of the major challenges I think almost all of us have faced is that the integration takes a much longer time. And if it actually doesn't happen, exposure and after that, rehabilitating the socket becomes a very big nightmare.
Any other postgraduates asking any queries or any want to they give some any comments? Postgraduates, residents, please do come forward.
Sir, in the interest of postgraduates, I'd just like to ask a simple question. The most common form that we see in our general practice is anophthalmic socket with a stock eye. The patient's coming in with discharge, redness, and all. So, what is the basic management that we can do, and when do we send them, and where do we send them as general ophthalmologists or as PPs who are sitting in the unit?
Actually, ma'am, just like if you are getting any patient who need a custom ocular prosthesis, or if the patient is coming with the infection and the patient is using a stock eye, so the main important thing is the counseling. Because as the patient for me, I have seen the patient using the stock eye. So most important thing is the counseling. So if you give a proper counseling, if you give a proper guidance to the patient, definitely the patient will go for a custom made ocular prosthesis. The main problem is the finance. The main problem is the finance, because that maximum this thing stock eye is given in just like medical colleges or the hospital, government hospitals. So they are getting the this thing stock eye either free of cost, maybe they are getting in 1,000 rupees. So asking the patient to pay 10,000, suppose. So in that situation, the patient is getting just like confused. So the same thing I'm going to get the eye only, whether it's a medical graded or non-medical graded, it doesn't matter to them. So the most important thing for any patient is the financial background. If they can afford little bit also, we can counsel the patient for the custom-made artificial eye. Suppose if you are getting a patient with just like discharge or infection, you can start with the just like if you find with the pyogenic granuloma, there is significant swelling in the socket. The best way to treat those patients, simply place a conformer start just like either we can start a topical steroid with antibiotic, just like we are giving Vigamox and Npred, just like Vigamox for 2 weeks and Npred for around 5 weeks, just like normal in a tapering manner. So with the help of steroid and moxie, we can control the infection. Once the infection is okay, after 6 weeks, you can call the patient and you can counsel the patient to go for a customer made artificial eye. If the patient is from the weaker section, there are lots of institute who offer the processes very reasonable prices, just like LB Prasad, Arvind Eye Foundation, Shankar Netralaya. So there we have a artificial light very reasonable rate. Means it's affordable, it's available for everyone. Particularly in LB Prasad, it's available for everyone. It's nothing like that a particular section only can avail this kind of eyes. No, even for us also we have NGOs like Can Kids or ICSA Foundation. Even we are supporting the patients also. So affording a custom-made artificial eye is not the problem. Sending the patient to a particular place, guiding the patient is the most important thing. So if you're getting any patient with a severe infection, you can start with the normal antibiotics and steroids. Or if you're finding there is a little bit the socket is hyperemic, mild infection, you can we can simply start with tobramycin or moxifloxacin. But most important thing is the counseling. You can just like show some pictures from Google so that they will understand the importance. And everybody want, particularly the one eyed, the main problem with the one eyed, not the cosmetic comfort. People can manage with the cosmetic thing. If the process is not looking good also they can manage, but they can manage with this thing cosmetic, because not only discharge with the stock eye, if they're not cleaning the stock eye, if the stock eye is 3-4 year old, they start getting foul smell from the prosthesis. So even if they go anywhere, they keep getting the foul smell. So that is the main problem, because a few patients, they keep complaining me that my wife don't like whenever I go closer, she's getting foul smell from me. So because there will be problems like that. Similarly, in case of mucormycosis, also black fungus also, as sir is saying, uh, just like waiting period. So even we have waited for 3 months, 4 months, still we have lots of patients who don't have just like due to this thing infection, there is a skin melt, so there is just like complete necrosis, everything is open. So nowadays in Apollo or multi-specialty hospital, they have started doing this skin graft. Few of them are successful, few of them are still struggling, because even in case if they have removed this thing now, maxillary bone, so the challenges come there only. Because last week only I have done one case, is also post mucormycosis, but that skin was intact. So the main case of, in case of exenteration, if you have skin, so we are lucky, particularly ocularist, because the main problem with the mucormycosis is not the cosmetic rehabilitation. For any exenteration processes, if it is lid sparing, if the skin is intact, patient is happy, we are happy. Even for me, I don't encourage them to go for any kind of prosthesis.
Sweeney, any comments from you, Dr. Sweeney?
No, sir, I've learned lots. Means I didn't know much about the customized eyes and all. I wanted to, but at Mahavir Netralaya, I'm giving the stock eyes. But it's, and moreover, I can't take the measurement with one answer. So that's another problem.
Sir, definitely will help you out. You can send someone, will train them within give me 1 month or 2 month time. Definitely, if you need any kind of facilities like this, you can send your optometrist for 1 month training. Definitely,
Yes,
we can teach them, sir.
yes, because my word side doesn't work, so it's difficult for me to take the measurement. Even
Yeah,
the
yes,
stock
sir.
I have a problem.
Yes, sir. We actually the main thing is the training. If you have
Yes,
optometrist who is interested in this, we can train them so that we can just like
yes, sir, that
spread
can be
the
done. That will be
awareness.
very useful for us.
Yes, yes. Main important thing is the training and this short-term fellowship, sir. Because for me, I've done 2 year fellowship in LV Prasad, but I can train someone in 1 month time or two
It is
month
very
time more
expensive,
than
sir. It is very expensive.
what, sir?
Training is very expensive.
No, 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 no. We are not charging 1 rupee for the training, sir. Training absolutely no charge, sir. For the setup, it will
Okay.
cost you around somewhere 50 to 75,000 rupees. That's it, sir. And that you
Okay.
can buy from local market. Nothing like there, no monopoly, nothing, sir. You can buy from your local vendors, sir. Just like
Okay. So
who is supplying
where
dental
can we send the
product.
patient for? Where can we send our staff for the training, sir?
Yes, yes,
Which place?
yes.
Which place,
Center
sir?
Center post site, sir. Banjara Hills, Hyderabad, sir. Dr. Santosh
I
Sonawar.
have got trained there. I have got trained from there also. There are Deepak Bagga there
Yes,
at
yes,
my
Dr.
clinic,
Yes, yes, Deepak Bagga.
because I did visual rehabilitation from there after Shankar Nethralaya.
Yes, yes, sir, yes. Dr. Deepak
And
Bagga.
yes, sir. I learned there a lot, sir. They give occupational training
Yes, yes.
for the daily users, sir. So it's a very good thing, sir. I really learned lots today. I never knew about so much things, sir. I knew the bookish language, customized is much better. But so many things in details, as every point in details I didn't know. So really, thank you very much. Thank you very much for including me, sir. Thank you.
PNR, you are waiting for something?
Yeah. Somebody is asking the questions. I was waiting.
No postgraduates will speak. Don't worry.
Dr. Prasanjit, would you like to have some any comments? Dr. Prasanjit Das, I think you
Yeah,
are
yes,
there.
sir. Yeah, I would like to ask whether do you use tensor fascicular graft and all for filling up the socket? Hello.
Yes, sir.
Do you use tensor fascicular graft or anything else to fill up the socket?
Actually, we are for anything just like if we need a socket reconstruction, sir, or to fill the socket, we are doing, sir, DFG, dummies fat grafting, sir.
Double?
Dummies fat graft, sir. DFG.
Yes, sir.
Raju, let me take that question. Actually,
Yeah, it's better.
essentially, so most of the time when you are looking at a socket reconstruction, the general way to look at it in front examination is, do you have a surface deficit, which means that you don't have enough conjunctiva? And
Yes.
whenever you have a surface deficit, the thing that you see in the clinic in the socket is that the phonesis will be shallow. Now, depending on how many phonesis are shallow, you have a classification system which will tell you how bad is the socket contracture. But the other aspect which is equally important is the volume deficit. So volume deficit would show up as a deep superior sulcus. And most of the earlier on enucleations or eviscerations have been done without an orbital implant. You would see there is a very deep sulcus, and that tends to tell you that the volume deficit is there. So the general thumb rule that we go by is, if you have a surface deficit, you have to bring in some sort of a surface. And the most common one we use is a mucous membrane graft, which is harvested. If you have a volume deficit, you have to bring in orbital implant, which has to be secondarily brought in. And if you have both surface and volume deficit, then what you get is a dermis fat graft. So which has a combination of both surface and volume. So its own patient's own fat taken from somewhere else, which helps in the volume and surface. Coming to your question on tensor fascial lata, it is predominantly used. We use tensor fascial lata predominantly for, let's say, for a fascial lata ptosis correction in anybody who has a very poor LPS action. We also do it for lag of thalamus, let's say, related to paralytic seventh nerve palsies and things like that. But for the surface, tensor fascial lata doesn't form a very good, a substitute, because it doesn't have, it only forms at the best a scaffold. It is known for its inherent tendency of a very good tensile strength. So that's how it works very well. But to be able to reconstruct a surface, we want actually some sort of a mucosa, which will be able to form an epithelial lining. And that's why usually either hard palate can be used, or mucous membrane, or even nasal mucosa can be used.
Thank you.
Thank you.
Just one query.
Yes. Yeah.
I mean, after how many days do you remove the prosthesis and sanitize it? Tell the patient to do it every month, week, or you just leave it like that? Because that is one thing which the patients do ask.
Sir, we need to, I advise the patient to clean the process once in a month, sir. And just take it out, clean with just like a Johnson baby shampoo or any baby shampoo or hand wash, replace it back. In case of a few patients, suppose if the patient is unable to close the eyelids, so in that scenario, sometime I tell the patient to clean the processes every alternate day, or just like while taking shower, clean the processes externally also. There are lots of patients who don't want to take out the process, particularly in case of pediatric patient now, that due to emotional attachment, parents they don't want to take out the processes. So in that kind of scenario, if the patient is just like on a regular follow-ups, if they're coming just like on a 3 monthly follow-ups, so in that scenario during UA means during anesthesia examination, we used to clean the processes. Or if the patient at all, if they're unable to clean the processes, so I used to refer them to a local ophthalmologist or our colleagues, so that they can go there and they can get done the process clean. Once in a month is the ideal time to clean the processes. And one more thing is that discontinuing at the night time, particularly in case of post-surgical cases, we don't encourage the patient to just like keep the processes on the bedside while sleeping. In the morning you can place it back. It's not an ideal thing, but in case of thysical eye, if the patient is unable to tolerate the eye, we advise the patient to take out the process at the night time if there is some corneal sensation.
Right. Thank you so much.
Very nice talk, Mr. Raj.
So I think it's time for thanking everybody. Anything left? So once again, I thank Mr. Raju giving us a widespread view of this ocular prosthesis, and a wonderful discussion with Dr. Sureshnath, giving his expert comments throughout the webinar. And really, I thank the panelists. I thank Dr. Priyansa moderating the session very well. And of course, I thank all the EIZOC officials. Today we have everybody, our president, secretary, then CSC, and ex-presidents, past president too. Thank you very much for joining with us, Dr. Pranamji. It's really wonderful discussion today. And as I told, this is the last episode in oculoplasty, and we are moving to some other specialty from next month onwards. And for your information, we started this oculoplasty webinars on 19 December 2023. So when Dr. Ajit Babu told me that oculoplasty, I said it will be over with 3-4 episodes. But you see, more than 15 months we continued this with having 17 episodes, starting from the anatomy to the last by Dr. Raju about the prosthesis. So really, it's a wonderful discussion. I think residents must have learned a lot in these last few months. So we move on to next faculty from next month onwards. So again, I thank my mentor, Dr. Ajit Babu, giving us very good speakers and topics in our ORTS series. Thank you all. Last but not the least is our platform provider, Entered Pharmaceuticals, where is always with us in all the episodes of both ORTS and RP. Thank you all. Good night.